So we would like to welcome our second panel. Mac Haddow, our federal advocate and lobbyist, will be moderating the panel. Mac has had a long career in healthcare here in Washington, D.C. And then Mac will introduce the rest of the panelists.
Yeah, thank you very much for everyone for being here this afternoon or this morning, and welcome. Just by way of introduction, we'll ask each one of the panelists to give a brief introduction of themselves and their organizations that they represent, and then we'll have a broader discussion about our topic here, which is going to explore the EPIC Act as we go forward. So I'll invite panelists to go down the line to make introductions.
No red dot. There we go. Good morning. Thank you all for coming, and thanks for the invitation to share with you today. My name is Dean Suhr. I'm from Oregon. I am president and co-founder of MLD Foundation for Metachromatic Leukodystrophy, lysosomal disorder. 2 of my 3 kids have this disease. One passed away in '95. The other was supposed to pass away 5, 6, 7 years later, and we're still traveling with her and vacationing and so on, so we're blessed by that. But I've been very active in policy, and particularly this whole area of access and reimbursement, as well as newborn screening, detecting children. We have a gene therapy that is under review at the FDA right now.
There we go. Hi, my name is Brett Kopelan. I'm the Executive Director of the Dystrophic Epidermolysis Bullosa Research Association of America. It's a terrible email address, so we go by our acronym debra. But more importantly, I'm the father to, actually in a couple days, 16-year-old girl with a particularly severe form of EB. Much easier to say than epidermolysis bullosa. Like Dean, pretty active on the Hill with the FDA and in drug development in general. We recently realized our first gene therapy, topically applied, redosable, the first redosable gene therapy. And got involved in EPIC with Dean and others because of some of the access issues that forced my family to move from New York City to Colorado. We lost our insurance coverage. We had 90 days to sell our house, to buy a house, and move, all during the summer of 2020 COVID. So otherwise we would have had no insurance coverage, and we order about $84,000 a month of wound care supplies. So without that coverage, we would have been broke very quickly. And so I appreciate the invitation to be here today, and thank you for the time.
Good morning, everybody. Jayson Slotnik. I'm outside policy consultant to RAAP, and appreciate everybody's time today and look forward to the discussion.
Great, thank you. And just by way of perhaps an anecdotal silver lining about the decision that we're facing here, where Senator Klobuchar was unable to join us because of a conflict unforeseen, I was in a similar meeting like this in the early 1980s when Senator Kennedy was supposed to speak at a luncheon during the meeting. And he had to cancel because of a weather issue in getting out of Boston to come here to D.C. And so there was this great disappointment, but I was sitting around with some people there that attending this seminar. I'd been sent, frankly, by Senator Hatch to actually hear what Senator Kennedy was going to say, because at the time there was some tension between the two. Senator Hatch had just taken over as the chair of the Help Committee, which was then a different name, and his relationship with Senator Kennedy, whom he had deposed because of the election, wasn't great at the time. And they, of course, mended that relationship and had a decades-long friendship later. But I had a conversation with a person that I would not have met except for the fact that Senator Kennedy canceled. And it developed into a decades-long friendship where we were able to abuse that friendship with one another by taking advantage of knowing each other and building relationships and networks with other people. So it was a great thing. And about 8 or 9 years later, I was sitting in the hideaway in the Capitol with Senator Hatch and Senator Kennedy in a late night meeting, and Senator Kennedy asked me, well, what's the most valuable thing that you've got out of being able to meet with Senator Hatch and I in these kinds of discussions and my relationship? And I said, well, actually, it was someone that I met because you didn't show up to give a speech at a thing. And he said, well, maybe I should quit going to these meetings and everybody can replicate that experience. So take advantage of it. I think it would be a great opportunity to meet someone. My involvement with RAAP is not just because of a commitment from a client relationship. In our family, we have suffered with some conditions, Crohn's, which is not necessarily rare, but debilitating and challenging in our family, and we have many with Crohn's disease in our Suhr family, and then have a grandson who has hemophilia, and it's difficult. But it pales by comparison when you hear the experiences of families that meet these challenges every day in order to deal with rare diseases and the impacts as caregivers, as parents, and as family members, and it is truly humbling to consider why these kinds of meetings are critically important to inform the public policy that surrounds this. And I can tell you, and I'll conclude my part of this with a confession. In the early 80s, I was in the Reagan administration, the chief of staff at the Department of Health and Human Services, and at the same time was the acting administrator of HCFA. And we were in this huge negotiation with the U.S. House of Representatives about a particular healthcare policy that we wanted to have done. We had enacted the DRG system, which squeezed a lot of money out of the healthcare system. We were also looking at restructuring Medicare. And we had an all-night negotiation session. And the chair then of the Energy and Commerce Committee in the House had told everyone in this meeting that he was going to leave at 4 a.m. And we either had a deal then or we didn't. And so we were rushing towards making that deal. And unfortunately, we struck a deal on a program that's called the Medicare Advantage program about what the balance would be between the commercial participants and Medicare participants would be. And we came to a number of 50%. 50% had to be commercial patients. Now, there was no data that drove that decision. It was a late-night, under-the-gun decision, and we plucked a number, and oh, guess what, 50%. It was a colossal mistake as we watched that program evolve and the restrictions that that placed on access that Medicare patients would have in that program. It reduced the number of available Medicare Advantage programs at the time, and seniors flocked to them because it expanded benefits for them in terms of available services and outside of the traditional Medicare program that they got for their fee-for-service. We made a mistake, and I only say that because this happens in legislative negotiations, and it happened with the IRA. We know that. And sometimes there are unforeseen consequences, and sometimes the groups that are left out are rare disease patients, because those that are looking at the overall cost sometimes ignore the unique circumstances we face here. And so the EPIC Act is a technical correction to legislation that has been enacted over the past 2 decades, maybe a little longer in some cases, where fixes have to be made, because we know that it's not just a tune-up, it's something that has to be fundamentally restructured in some cases in order to allow for patients and their families to have access to therapies that right now the system gets in the way of doing that. These are challenging things because there's always a cost associated with it. How do we find the offsetting revenue in order to pay for these things? And obviously, anytime there's money involved, somebody is going to be left on the floor having taken a haircut, and we know that. But sometimes those people are the ones who deserve to do so. Sometimes we're going to have to add money to a system with traditionally groups that we don't particularly favor generally. We all know the big, bad pharma companies. They're awful people, right? They're the only reason that we have these therapies that are life-saving. And the tension that often exists between patient advocacy groups and the pharma industry, which is enhanced by sometimes the well-meaning but misplaced efforts by congressional staffers that get in the way of those negotiations, don't generate good public policy. That's why the EPIC Act is so important. We need to start restructuring, tweaking it, making these technical corrections as we go forward. So with that introduction, I'll ask each of the panel members to provide their perspective on what value the EPIC Act will provide, its feasibility for passage as we look forward over the next year of session of Congress, and your personal perspective on how we got here in developing the EPIC Act itself.
Excellent, thank you. And I would say there's another part of that audience you talk about that's viewing big bad pharma, of which I'm a partner with and appreciate and love. Actually, a lot of it's small biotech, but is the general public. So it's not just what we do and what we're working on, but how things are perceived. And I think that can get in the way of a lot of this as well. So EPIC RD, that little RD tag at the end of it, this is focused on rare diseases. The roots of this come from a group of advocacy organizations, and I should call out Terry Klein out there from MPS Society. She's part of this group I'll be talking about. And there's an empty seat on the panel if you want to wander up, or if we say something wrong. But about 3 years ago now, I believe, 3.5 years ago, just about the COVID time, about a dozen of us got together and started just talking about what are our challenges in this access space. In the rare disease space, kind of the general rule of thumb we use for patients is about 50% of the patients are children. 50% of the children of the patients are on Medicaid. And that is a real struggling point for us. And as we all know, Medicaid is state-level policy, so the policies vary from state to state. And so when we have these challenges with rare diseases, we have to we struggle in fitting into kind of that standard flow in terms of all the challenges with access and reimbursement, particularly when it's a government program and it's got a structure and a momentum and so on. So about a dozen of us got together, started bouncing around these concerns and these ideas, and for better or worse, it was pretty easy to come up with a pretty long list of things that we wanted to, that amongst us, that we wanted to see addressed. And we started trying to whittle that down and realized that there wasn't a lot of whittling to do, that these things are problems. They're a little different from one disease to the other, but generally we're all experiencing very similar problems and challenges. So we started talking about now, what do we do with this? How do we take some action? How can we get some change or some improvements? And that is what led to this legislation. We're fortunate to have been partnered with BioMarin and some of their staff, so we've had some of their resources and support, and you'll see, for compliance reasons, at the bottom of all the paperwork, and I hope you all have picked up one of these on the way in. If not, grab that over lunch or on your way out. But it says supported by BioMarin, but more importantly, it's been developed by advocacy. This group of advocates, it's dwindled. We're probably about half our starting group that are actively engaged. We're meeting very regularly, and we have turned this into legislation that indeed is EPIC. And ensuring parity through individualized care is what that stands for, to be consistent with the acronyms on the Hill. But it's also EPIC, and we acknowledge that there is a lot of detail. We're covering a lot of ground. As we talk over the next few minutes through some of the pillars of this, you'll say, oh, well, that's maybe part of that legislation, or that's being addressed here and there, and that's all fine with us. We don't care whether this goes through as one big bill, smaller bills carved off, whatever. We just want to see these problems addressed. But we thought that the focus needed to be broad and comprehensive, so that as you're thinking about maybe this, you don't forget about the other pieces. We know that making the sausage here on the Hill takes all kinds of ingredients and processes and steps, and we're flexible with that. But that's kind of what got us to EPIC RD over the past 2 or 3 years. Where are we? This is kind of our first public coming out in a broad-based forum environment. We've been doing a number of visits on the Hill. There's not a bill number. We don't have formal co-sponsors, sponsors or co-sponsors at this juncture. We're really, as I kind of joke, we're kind of in the elementary school process of this, and we're just becoming junior hires. We're just trying to really, get our cliques and our groups and our momentum and our efforts in place. But I think very quickly now, because of the feedback that we've been getting from coalitions and groups such as this, and frankly, the responses on the Hill as well, that we're going to be able to make some dramatic progress. As to whether it's completed in this Congress or not, that would be a big question, but that's okay. We're knocking on those doors and whittling through. So maybe I'll turn it over to Brett, and you can continue on.
Sure. Well, we have socialized this before, not in this. I mean, we've met with some elected officials, and of course, the first question is always, what's it going to cost? Always. Even before you have finished saying good morning, what's it going to cost, right? But the most important part is it's all about access to different things, whether that be the therapies that are being developed and commercialized now, whether it be medical supplies or whether it be access to physicians in a cross-border or cross-state concept. The heart of all this has been access. We realize that it's a monster bill, so EPIC has become much more of an umbrella term for us, and we've really broken it down into 3 pillars at this point. And yes, we would merge it with other bills out there. We would have other bills merge into this, whichever. Because one thing that you learn as a rare disease parent is to adapt, change, modify, and move forward. So the 3 real pillars that we've had here is access to rare disease therapies, certainly as they come to market. And as we heard earlier, the IFA is certainly, or the IRA has been problematic. Everyone's moving to small molecule drugs now anyway. And places like BCG and others are telling people to move to small molecules, so hopefully that doesn't hurt us in the long term. Anyway, back to this, sorry. Access to specialized care should be easier. When you have a rare disease, you most of the time have to go to a number of different institutions across the country in order to get holistic care. So when we were in New York, we had to travel to Cincinnati every 2 months in order to get care. We have been seen at places like Children's Hospital of Philadelphia, Columbia University, University of Minnesota, Colorado Children's, Cincinnati Children's, what I'm missing, 5 or 6 places that we've had to go, and we've always had struggles in having the physicians be paid for. Were we allowed to go see? This could be, Cincinnati was the only place where my daughter could have dental work done in the country, right? And dental caries are a big problem within our disease. It's also the only place where nurses are trained in the simplest of things like securing an IV. Sounds pretty simple, right? Securing an IV. There's something out there, it's pretty much duct tape, clear duct tape that they use to hold an IV in place, and that is, in many cases, would take the skin directly off of a child's arm. So just having a nursing staff that understands some of the other advanced bandages that need to go through the purchasing departments, and so it's important for people to have access to the 4 or 5 centers in the country. And now that's an embarrassment of riches for our disease state. A lot of places only have 1, center of excellence that can treat holistically. So the fact that we have 4 or 5 is pretty impressive. So the need, it's more than just medicine. It's supplies, it's wheelchairs, it's medical equipment, supplies, medical foods. My child can't eat because of all the wounds inside of her mouth. If we didn't have tube feeding at night, look, we're lucky to get 1,200 calories in her a day, and her caloric needs are more along the lines of 25 to 3,000 as a tiny 15-year-old. So it is critically important that patients have access to all of these things. The new drugs that are out there, clearly, for us, the gene therapy, the topically applied, is healing wounds, which is the hallmark of our disease. It's an inability to produce a protein that allows the 2 layers of skin to bind together. So this actually delivers a working copy of the gene, an off-the-shelf gene, which is pretty impressive already, to 2 different type of cell lines. And these wounds are healing, and they're healing within 3 to 6 months when these wounds haven't healed in years. So if you can think about that, and if 60% of a body is an open wound, it may take a while to really change quality of life, but we have seen such a dramatic improvement on some of these wounds that we're looking at. The most important thing that we've seen is the change in hope, right? And a good state of mind will get you out of a bad breakup. A good, it will get you out of a bad time at school or being in this building for too long sometimes. So, again, the 3 pillars, incredibly important. All are very necessary, but we realize in order to move this forward, we had to break it up a little bit because you have to allow the state Medicaids to have flexibility in what they offer, but we believe there should be a minimal standard.
So one of the important things that Brett just mentioned about these 3 pillars is that not only does it serve to educate the members of Congress here, but it also serves to educate the actual state legislatures and the state houses. Because principally what EPIC is about, it's about modernizing the Medicaid program. Going back to when Mac was a young man, when Medicare was invented in 1965, Medicare and Medicaid were principled on the fact that all health care is local. And for those, particularly the parents here, know that having somebody, a loved one, who is suffering from a rare disorder, that is not a local access enterprise in healthcare. And over time, Medicare has evolved to some extent related to allowing for more of a broader network for access for care, but Medicaid has not. So one of the principles, one of the pillars that Brett just mentioned is across state boundaries, right? And it's very complicated. It's a morose of paperwork if one patient, particularly, right, you think about this in the Northeast, you think about where other parts of our country where states are clustered, where one patient needs to go across state lines from Massachusetts to Rhode Island, New York to New Jersey to seek the specialist who can freely move, by the way, between the states, but the patient cannot. It becomes a significant barrier to access for patients who are living with a rare disease or disorder. And the EPIC Act really goes to serve to try to solve that problem for families. And it's a crucial piece of the puzzle, the access puzzle, that is. And special thanks to BioMarin for really blowing this up as an issue, for you guys for educating the Hill on it, and hopefully all through the state houses as it relates to how important it is for the industry and the patients we serve to break down those cross-state barriers. Number 2, the way that the EPIC Act tries to modernize access in healthcare, in Medicaid particularly, is through formulary review. And so what happens now today is that this manufacturer signs a rebate agreement with the state. It's a quid pro quo. You state, you have to cover our drug. We give you a 23.1% rebate. It's a little lower for pure pediatrics, but that is the quid pro quo. Within that, the states are, in their mindset, right, they have to cover it how they're stuck, to use a bad word. So they have other tools, they try other tools to prevent immediate access or ensure appropriate access, if you want to use some bureaucratic language. So what has occurred over time is that 6 months, 9 months, 12 months go by before the state reviews the drug, puts it on its formulary, and allows patients and families access to the drug. What the EPIC Act does is really expose that in 2 ways. Number 1, it says, look, you states, these patients are, right, by definition, they are accessing a rare therapy. You need to provide patients, providers on the review committee who actually know what's going on here in order to review the drug and make that process fairer to the families, number 1. Number 2, you need to do it in an expeditious manner, right? This delay is reprehensible in a lot of ways. So to me, those are 2 very important factors of EPIC. I agree with you. To me, who cares how it gets done? Let's get it done, right? And applaud your efforts in getting that. Education on that. CMMI, which is a part of CMS, chartered with trying to develop new access models, is hearing you and understanding you. I don't know if you guys have had a chance to meet with CMMI on some of their models that they are focused on, particularly on the upcoming gene therapies for sickle cell. They are very focused on that. They recognize the cross-state issues in there, so I also encourage you, because you know the Hill talks to CMS a lot on that too. And then thirdly, as Brett mentioned, there are all these other tertiary services that are equally important, like feeding tubes and supplies that are also part of this that Medicaid typically, if it covers it all, covers at such a low rate, it might as well not be covered. So to me, I'm honored to work on EPIC. It is a tremendously important endeavor. 1 in 3 births in this country is a Medicaid patient, and so we need to, as a society, really do a better job in providing for Medicaid patients. So I think, I think it was Brett or said that, get one of these on the way out, and let's bring it to the top of the floor, or the top of the pile.
Thank you to each one of you. Obviously, the big issue that always comes through is how are we going to pay for it? This is the challenge that all public officials have to wrestle with in balancing these issues. We heard on the last panel that the incentives that were created by the Orphan Drug Act, once it was properly amended to allow for the flow of those incentives to actually impact new drug development in rare disease therapies, that we opened up that pipeline. But the interesting thing is that as much as we incentivize the development of those therapies, and there's lots more to do, obviously, there wasn't a corresponding effort to make certain that once the therapies were on the market and available, that there was access to them by patients for which they were developed in the first place. So you have this huge challenge, and we've heard in a previous RAAP, or last year, I think it was last year, maybe 2 years ago, when we did a RAAP briefing like this, we heard the family of a child that had spinal muscular atrophy that was being denied because of the cost, a gene therapy that would have saved her life. And that family engaged in what was, from every respect, a catastrophic economic event in their family. But they desperately wanted to save their child, and it took the courage of a provider in Colorado, without any assurance that Medicaid would pay, that they actually dosed that child to save her life. And we experienced, while the mother was speaking, the child who otherwise would have been completely debilitated or dead was there waving. And you don't do that. Spinal muscular atrophy babies lose their ability to do it, but because the courage of that hospital. That should not happen, right? We know that there should be access once we develop these miraculous therapies. So from your perspective in looking at the EPIC Act, what is the solution that will reduce the need that Medicaid directors have to erect those barriers that Jayson talked about? Because they have to. They have to limit the access in order to accommodate budgets. So what's the solution EPIC provides?
So I don't think everything is about money, but not everything's about money. A lot of this is, and I hate to jump on the bandwagon of equity because I see it just kind of like an umbrella that we're now hanging everything on. But these therapies give quality of life, not just extension, but quality of life and or life in many cases. And the challenge, the broader challenge with rare diseases, and particularly in the Medicaid side, is that these therapies are expensive, but they're not available in your state because that's not where the center of excellence is. And you talk about a nurse that can deal with sensitive skin, or I don't know what the right term there is, to do an IV. I mean, I jump in and they poke me and I wince. That doesn't happen with your daughter at any site. So one of the key focuses here is coordination across state lines. The center of excellence, the doctor on the receiving end of that, the out-of-state doctor, needs to be certified by the sending state. That doctor needs to be reimbursed as if they were in the sending state. The same thing for whatever the therapy that you would hope would be available, in your home state. I mean, with MLD, it's not the gene therapy, but a different therapy. We sat, and I literally sat at the doorway to the office of the Medicaid review. You find out where those places are. They're not very exciting buildings. But I built up a relationship with the Medicaid review manager there. We were trying to get a family to get a therapy in Pittsburgh. You say they're right outside of Chicago, and Chicago has wonderful medical facilities. And in this case, it was a transplant, but they don't have MLD and inborn errors of metabolism as much experience. And we wanted this family to access the best experience, but we had to go through all of these hoops, and some of them were, we don't want to send anybody out of state. But a big piece of them were, we don't have a contract in place. We don't know how. We would have to do a one-off contract, and then how do you set the rates? And should there be a discount, or should there be a premium? You know, is Illinois a higher-paying state than Pennsylvania? I don't know, but there's just a lot of mechanics in there that we need to take those barriers away. So when we say access, yeah, somebody has to have a checkbook, but it's about how do you get to that point. There's another provision in EPIC that says if the FDA has approved your therapy, right? That's what we all strive for, is approved therapies. That label, however narrow, however broad it is the label you need to follow. The Medicaid system does not get to narrow that label because of perhaps taking another look at the clinical trial data and saying, well, you didn't have quite enough patients on this end of the label or whatever. It takes away that ability for, and I believe it's an improper ability, to be a second FDA, to be a second regulatory agency that says, no, FDA says this is good, but no, I'm smarter. I think this is where we really should be targeting. So I just caution that money's important, but it's not everything here, because in rare disease, you can't get everything you need in your local care center.
I'm actually going to answer your question directly, right? And here's the big problem. You need a longer-term view on this, which is the problem. We don't have problems in other parts of our budget in borrowing. We don't have other areas that we run deficits, right? The reality is this: in the long term, these therapies, these treatment modalities that need to be approved save money in the long run. You have to get beyond the living paycheck to paycheck, right? And you have to take the longer term view of this. We know that these gene therapies will reduce costs over the long term. What is that horizon? For us, in my prior world, Excel was my friend. I don't think I could eat dinner without Excel, right? And even now, looking at it as we've built an economic burden of illness model, and I've forecasted out the use and the costs of the gene therapy. It's $485,000 a year after rebates, looking at a 7-year return, right? And that's when the costs start going down. By the way, that's the same return that you get for a direct mail in nonprofit. It takes 7 years to get to profitability or to start making some money on it. So that's the approach we need to take here, and that's a difficult approach to convince people of at this point when it comes to health. And it's funny, it's really in health where that's the issue. It's not in every parts of the budget. And that's the argument we need to make, and those are the patient stories. It is quality of life, right? It is cost mitigation. And these things are possible with these expensive advanced therapeutics, but over the long-term horizon, you're going to show an ROI and a reduction in cost.
So this budget window, maybe Jayson can address this. We know traditionally that the Congressional Budget Office has this black box where they do all of their calculations and they produce a projected impact on the budget. And everybody just rushes to that and say that's the gospel truth. So that's the framework we have to operate in. But what you've just expressed here, Brett, is the need to look beyond that budget window, to look at the cost recovery and the true long-term continuum of care cost in these situations in order to properly evaluate it. Jayson, how do we get over this hump with?
Well, what's interesting is, you mentioned the federal side. The congressional budget window is 10 years. What Brett is mentioning is that in many states it's 1 year. Right, and so that's an impossible paradigm for a family to run up against with a child who's on Medicaid, because that's just wrong, right? I mean, I don't know who. It's an indefensible position to say, well, I have to make all my money back on this year on the therapy. So I completely agree that we have to do a better job sort of explaining that or maybe not explaining, but just sort of help them fix that, right? Maybe it's got to do a better job at the state legislatures in order to sort of allow for more than a one-year ROI for their budgets, because they know if they're spending the $2 million this year on the gene therapy, they have to find the $2 million to balance that budget. So that is something that, from an operational point of view, is a really unfortunate challenge in access at a lot of the states currently. And secondly is sort of a bigger philosophical picture, which is sort of to say, yes, not all healthcare spending should be budget neutral, right? What else as a society should we be investing our money in than the healthcare of our children and, and like you said, equity from a Medicaid population? So I challenge the principle that all healthcare spending should be budget neutral to begin with, but that is also a significant uphill battle. But the two sort of merge when you get to this situation where you have to, unfortunately, manage state legislatures' requirement to balance their budget on an annual basis. And in other healthcare groups across the town here, when trying to engage with one possible solution, which has been value-based contracts and value-based agreements, this is where we've run into these problems, which is how I sort of know about it. So it is and why I go back to my early comments about education and, right, what you guys are doing is great. I would like to see some of this EPIC Act become an EPIC at every state in a lot of ways.
We went through the process this past year in the MLD community with an ICER review. And I got to tell you, going into that, I was pretty shaken in my boots. I didn't know what to expect. A lot of the discussion about ICER is less than complimentary. But I do have to say that the process was transparent. It was very interactive. We were an expert reviewer, so we were kind of helping to drive and educate them. And it turned out pretty good for us. And I just want to reinforce what Brett said. They're looking at, and again, I'm not a fan of quality of adjusted life years and all that kind of measurement, but using that scheme, to use the British term, using that approach, it said this multi-million-dollar therapy, $2.4 to $3.7 million was the price range they gave for it, is cost-effective in our community. So having that data, having those numbers, the Every Life Foundation, those of you that aren't familiar with their recent couple of studies, one was the burden of rare diseases. I think they did that 2 years ago, 3 years ago maybe, and they just came out with another one, which is the cost of deferred diagnosis. Both dramatic numbers and only looking at a small subset of the rare community. I would say the good news, bad news is, from a budgeting perspective, is rare diseases are rare. So that even though it's a multi-million-dollar therapy, there's not going to be a dozen patients in Oregon with MLD. We've been around for 20 plus years. We kind of know what the birth rates are in the various states, and we're not going to have that many in Oregon. You won't get that many here in Virginia or Maryland or whatever either. So the millions of dollars are not times thousands or tens of thousands. They're times handfuls. The bad news is, if I put my budget hat on, though, is that gene therapies and some of these expensive therapies are being developed and studied and submitted to review at an ever-increasing rate. We're figuring out how to, all the smart people are figuring out how to turn the crank on these therapies and replicate them in multiple diseases. So pragmatically, we do need to be thinking, not next year's budget, but 5 or 10 years out, what's the cumulative effect of a lot of these expensive therapies. And gene therapies aren't the only expensive therapies, just because we're at several $1 million with wonderful results. We've been using transplant for a number of years. That's a $500,000 to $700,000 therapy. It's not small molecules, but small molecules, even with a small community, they need to get a return on the investment there as well. So this is not just a gene therapy problem. This is an overall community problem.
By the way, one other thing about access here, it lowers costs. When you provide access to specialists that can help develop a treatment plan, you end up spending less money over the long term. So this is kind of like, build your basement now before you build your house. Otherwise, you got to build your basement later on. right? Or at least the structure. And so, yeah, I mean, like I said, we're not living paycheck to paycheck. It's hard, the balanced budget concept. It's hard to get over, but these are the arguments that we need to make in this. Rare diseases, 10% of the population, $1 trillion in healthcare spending? $1 trillion. We can reduce that cost.
That's only 300 of the rare diseases,
Yeah.
of the 10,000 plus diseases.
So we have a panel on state issues, and I don't want to traipse too far into that area, but as Jayson appropriately pointed out, the relationship that state budgets have in dealing with federal allocations in the Medicaid program are obviously limited by the different budgeting windows they use. State legislators are dealing with a balanced budget requirement year to year. I think even in some states, if the legislators fail to balance the budget, they're subject to be incarcerated. And maybe that should be true in every state, and maybe here in Washington. But that not being the case, this is the reality of what we have to face with. So in that respect, how is it that we can confront this tension where in state legislatures, the private pay insurers come in and make their arguments about how a high-cost patient is going to destroy and drive up premiums, destroy the equitable distribution of premium allocations. And state legislators have to deal with that, and they are not typically insulated by staffers who can protect them from all of the advocates on both sides. And we all know that insurance companies have large budgets to fund lobbyists who have direct relationships with these state legislators. So that's a real problem. How do we break through that on a state level to make sure that state legislators understand, and how can we empower them to account for rare disease patients? And what's your experience been in having to break through those barriers?
Well, for my family, we, on a personal basis, we actually pay for private insurance for my daughter, who is on Medicaid, because we can't get what we need or what we want her to have for quality of life, access to therapies and resources, and she hasn't had a life-saving therapy. She's terminal. But we can't get access to all of that just on Medicaid. So my heart goes out, and I speak to these families all the time, where their only access to any services is through Medicaid. It's not in EPIC, but one of the things that has been brought up as we've been floating this is some sort of concept of maybe even a reinsurance, and that's probably the wrong term to use in the federal side of things. We see this in the private market where maybe an organization is self-insured. I had a situation of working with a family outside of Houston, a firefighter, and they needed access. They were getting access to the gene therapy, and we ended up talking to their insurance company. Come to learn, they were just managing self-insurance, so they're the operational side of that. But they use self-insurance reinsurance for these large budget items. So that's something that might be worth considering. I don't know the logistics or dynamics of that, but where the federal government comes in and says, you know what, Oregon or Rhode Island, pick a small state out here, you may not have the resources to deal with this, but we can come in and provide some of that support. And likewise with maybe some of the larger states, if we're not spending as much as we forecasted for some of these therapies because the patients aren't being identified or for whatever reason, that there's a way of we can't take from one state's money to the other, but if there's an overlay of sorts, there's a way of balancing that out.
I guess they call that risk pools.
Yes, well, yeah, exactly.
Right?
Exactly.
No, and the other thing to realize is not all state Medicaids are created equal. We didn't have the ability to have commercial insurance for my daughter. Oh. Our insurance plan raised, this was not the first one to do that, but raised our premiums 500%. It went from $2,400 a month for a family to $11,500. So we did not have an option. No insurance plan would provide us coverage, and reasons why you don't go to the healthcare.gov. But so we needed to pick a Medicaid that she is Medicaid dependent. We had to leave New York, generally considered Medicaid rich. It's not. I mean, it does have money, it just doesn't spend it very well. And Colorado has proven itself to be probably one of the strongest Medicaid children programs in the country. We got a gene therapy approved for her within 30 days. She gets everything that she needs. All her medical care is better than Blue Cross Blue Shield, Aetna, United Health combined, right? So once we start looking at, okay, not all states are created equal here, and that's where the minimal sort of coverage requirements have to come in, whether it's a reinsurance model, a risk pool, something along those lines. And unfortunately, I mean, here's the sad truth. It's not going to happen until a president's daughter has a rare disease. That's when it's going to happen. It's when a senior senator, name the state, has a kid with a rare disease. Things change, right? And, that's the unfortunate part. No matter how much, and I have screamed into the wind at this enough times. I understand budgets. I live on a budget. Right? I get the need, but, if I need to, I have credit cards and I can borrow and I'll pay them off over time. Right? And I think that's still when it comes to, you've heard people say our children are our future and all that kind of crap. Well, it's time to put up or shut up. Right? This is 10% of the population that has this problem. Right? And this is something like EPIC. This is one of the reasons why Dean, Terry, we got together, because it's not just about our disease communities. Right? It's about all the kids. There's no such thing as a good pediatric disease. Not one. Right? Atopic dermatitis in a kid is going to be difficult, let alone some of these other much more complex, isolating diseases. So that's why the EPIC RD concepts of access across state lines for treatment, to streamline prior authorizations, to streamline the process of when you are denied. It took us 8 months to get a wheelchair for a kid that can't walk, right? That was in New York. In Colorado, it took 17 days. So they're not all created equally, and this is where that minimum standard has to come in. And this is something that EPIC, by title, kind of wants to ensure.
We've danced around sort of the big picture here, which is which risk model does society want to choose, or maybe a mixture of them, to provide to provide access, right? Because nobody's paying for any of this directly out of pocket. This isn't like, right? And so we have a couple of different risk-sharing models, right? We have insurance, who then offloads risk to reinsurance, right? That's one side. What Mac mentioned is the other side, which is, if every person paid $2 more in premiums, if it was only $2, to your point, right, then we would spread that risk over a larger population. And what person wouldn't self-insure $2 more a month against a $500,000 a year disease, right? So it goes back to what I said before, which is those conversations aren't being held, I think, in earnest at the level and or in the depth at the level where it needs to be, which is at the decision makers here. And it may not happen until somebody really needs to own it here or at the state level, which is how can we best spread the risk such that everybody gets, the equity of access to care. And it might be a mixture where everybody decide, on a Medicaid managed care, everybody pays a little bit more in premiums and there's a reinsurance on the back end for the state. Or some states may want to do one or the other or something like that. But we have gone to the point where our clinical advancements are, where we do have these outliers, and we need to figure out a better way to move that bell curve a little bit to include and spread the risk a little bit better, and we haven't gotten there yet.
But I tell you what, I mentioned this earlier, we have private insurance and Medicaid for my daughter. My wife pays all the bills, so I don't know the exact numbers, but it's $400-ish or so per month for she's 43 for my daughter. So she's in the healthy age range, and we can't, no pre-existing conditions kick off and those sorts of things. The first 4 or 5 weeks of the year, the state Medicaid is paying for everything, because that equates to, and here's a different topic for a different bill, but the out-of-pocket and the copays, Medicaid in Oregon is paying for that. And then come February, sometime in February, the crossover occurs, and guess what? Medicaid, for the most part, skates. So they've paid whatever our $6,000 out-of-pocket is, plus $400 a month, so forth. So they're paying $10,000 a year for the care of my daughter, which is dramatically by at least an order of magnitude, if not two, above that. So there's a simple answer. Maybe if Medicaid would simply buy private insurance, which you could call reinsurance, you know, of course that would put a ripple effect back in the private insurance and so on. So nothing is as simple as you want it to be, but it can be done. And if I can do it once and we can do it 10 times for families or 100 or 1,000 times, we can start to figure those things out. But I think it was your comment, is well put, which is, should healthcare, you know, as it sits as a priority for us in this country, our values, does it have to be cost neutral? Should it, you know, or I shouldn't, should is probably the wrong word, but that, I think that's a fundamental assumption we're wrestling with, and it's not. It's not cost neutral. We spend a lot of money on health care in this country that's managed and comes through the government side of things.
I think much of the policy that we generate and that Congress often relies upon, as do state legislators, is driven by data analytics.
Yes.
And the data analytics sometimes, well, often does not reveal the true circumstances that they're left out by the data. Families that suffer, caregivers that are required. I mean, there are untold costs on families that, as you all know, with the person or family member having a rare disease that's not accounted for in treatment. It's lots of other things. And those analytics don't account for those kinds of things. We see at RAAP on a regular basis analytics driving policy at the state and federal level that's talking about high-cost drugs. And those high-cost drugs don't account, the analytics don't account for the fact that some of those high-cost drugs are rare disease drugs that do not have a patient population from which a good R&D recovery can occur in terms of the cost of those drugs. And it's impossible for the rare disease patient to meet that burden for the true cost of that drug. So obviously, we need to improve the way that we look at this. We need to improve on how we analyze how that data actually impacts. And some of the people that frustrate us are well-intentioned people. They think, oh, this analytics shows that we have to suddenly squeeze down on these costs, but they're squeezing out of that the very lifeblood of R&D for new therapies that are essential to look at the additional rare disease therapies or improvements in existing therapies of rare disease patients. I remember when I was that acting administrator at HCFA, and now CMS, I was tasked to go and give an award to a neonatal intensive care unit in St. Louis. And I used the talking points and I recognized this neonatal intensive care unit that had been credited with the best recovery rate for newborn children with difficult conditions. They were saving lives by the hundreds that other hospitals just weren't achieving. And we recognized them, gave an award. At the end of that press conference, the director pulled me aside and said, we really appreciate this, but we're shutting down in 3 months because of your DRG system. Yeah. Because you enacted the diagnostic-related groups, and those limitations on reimbursement forced our hospital to shut down the neonatal intensive care unit. Now, when I heard that, the response was, we found a creative way to keep them open. That's the challenge, is that when we identify these anomalies, these unintended consequences of data that ignore or undercount the reality, we have to find those pathways to correct it. And that's what EPIC does, I think. It provides Congress the opportunity to look at specific buckets of underreported, understood, not very well understood areas, and that's the key to it. So I'll let each of you finish with the closing comment before we break for lunch.
Yeah, thank you. That burden of care study that I referred to, the Every Life Foundation put out, identifies that the cost of rare disease on us as a society is not just how much did that drug cost, what was the hospital bill. I think it was only about 40% or so of the dollars are directly attributable to what would you find in an electronic health record or insurance billings. The majority of those costs are related to a parent that needs to quit, to take care of their, in this case, we're talking about children or their loved one. In some cases, both parents, modifications to their homes, things that aren't covered by their insurance or by their Medicaid. That could be travel to a specialty center. If you're not going to get reimbursed for it, you need to make that decision whether you're going to do what you're going to do for your kids. And I got to tell you, 9 times or more out of 10, parents going to do anything they can for their kids, and they'll deal with it later. Let Visa take care of it, or whatever it might be, or GoFundMe, or whatever mechanism that is. So we need to understand that we're not the patient is the focal point, the child in this case, but it's everything around them that's impacted. Not all of these therapies are curative, but when we talk about quality of life, does that mean that child is less of a burden financially, medically, as life goes on, in addition to having a better life? Does it mean maybe they can get a job and pay taxes and pay into the system that will benefit another child? Those things are important. Parents that stay at work or don't have to have additional child care or whatever, all those expenses. So we need to be thinking about this as not just, we always talk about 1 in 10 is affected with rare diseases. That's true. They have something in their medical record. But I would argue it's 2 or 3 or 4 in 10 that are directly affected. The parents, I don't know what it is, 1.5 per household. The grandparents, the neighbors, the pastor, teacher, boss, school bus driver, whatever it is, knows what's going on with that family. This is a society challenge that we need to step up to. What we've done with Epic RD is bring a big menu to you. There's a lot of choices. There's a lot of issues in here, and as we identified when we first started chatting, we're willing to attach bits and pieces of this. We're willing to be allies on whatever legislation you might be thinking of, or creative ways of moving things forward. We just want to deal with these issues. I really appreciate the time, and thank you very much.
As a caretaker, I just want to make life for other caretakers just a little easier. Just a little easier, right? We talked about what you give up, the unknown costs. Well, I can directly tell you how much income I've lost, I left a professional career, and a very well-paid one, to go into nonprofit, which is not very well paid, right? The amount of time that I have had to take off, that my wife, she had to quit her career, to driving to Cincinnati, which was a 12-hour drive, to stay there for 3 or 4 days, to come home. It's funny, I was recently rewatching a show called The West Wing. It's one of those shows I can watch 1,500 different times. Anything Aaron Sorkin writes, I'll watch. There was an episode talking about sending your kids to college and how it should be hard, right, to do this. This is our job as parents, to care for our kids. Just make it a little easier. I think Epic makes it just a little easier. And in the end, I'll take that.
Mike, you ready? Go on. I'll just say, as a swamp creature, I will say to keep. It's frustrating. The sausage making process is not pretty, as you guys know, but keep on trucking. I look at all the advancements you've made at the FDA, for example, right? Getting the patient voice heard at the FDA. There's been a tremendous progress the last couple of years on social equity, social determinants of health, identifying. Article in the Wall Street Journal today about being more inclusive in clinical trials. So while it's not occurring at a fast enough speed for anybody, sort of legislation never does. I encourage you to keep pushing, and we're all here to support you in your journeys.
Thanks to everyone. Now it's not.